Welcome to another round of the New Mexico Sentencing Commission's Education Series. Today we have Dr. Brady Horn with us to talk about cost effectiveness of jail-based methadone maintenance treatment. So a little bit about Brady. I've known him for probably longer than either one of us wants to admit. He works he's a professor in the economics department with a focus on public economics and applied econometrics. A large portion of what his research is dedicated to is applying applied health programs, and he's particularly interested in the safety net and disadvantaged populations. To address these issues, Dr. Horn has worked with researchers from many other disciplines, including law, psychology, medicine, and criminal justice to better understand how safety net programs can be best used to improve health and reduce disparities. Dr. Horn is also an appointed member on the New Mexico Sentencing Commission. This is the paper that we're going to be talking about today. It was done on published in 2020, excuse me. And if you would like a copy of this paper, go ahead and email either the Sentencing Commission or Dr. Horn, and we can get you a copy of that sent out. So now, without further ado, I am going to turn it over to Brady to kind of give you a background on the opioid epidemic, how methadone maintenance treatment can work in prisons and jails, and an overview of this paper.
All right, well, thanks, Nicole. Thanks, everybody, for coming, and thanks to the Sentencing Commission to let me show you my research. So this project has been ongoing for quite a while. Maybe I've been working on this maybe for 6 years now, thinking about how we could study basically incarceration-based substance use disorder treatment. And to do that, I'm looking at the jail-based medication-assisted treatment program in the MDC, the detention center in Bernalillo. There's a couple people on this paper with me. They're all from UNM except for Michael French. So Zhao Sui Li, she's a professor in the economics department. Paul Guerin is at the Institute for Social Research. And Barbara McCready is at CASA, which is Center for Alcoholism, Substance Abuse and Addiction. Okay, so just moving in, I know many people on this call probably know a lot about substance use disorders, but just for background, substance use disorders are a chronic mental health disorder in which the use of alcohol and drugs causes significant impairments such as health problems, disability, and failure to meet major responsibilities. They're prevalent. In 2015, 22 million US residents met diagnostic criteria for SUDS, substance use disorders, and they're incredibly costly. So they hinder overall health, employment outcomes, financial stability, and relationships. So they cause a lot of problems for people. So just for some facts, excessive alcohol use causes 88,000 deaths per year. 48,000 deaths a year are caused by cigarette smoking. And the cost of addiction in the US are over $519 billion. Okay, so while almost everyone knows that there is an opioid epidemic, here's a chart that kind of shows the progression. So in 1999, there were 3 deaths per 100,000 population. So this has gone up a tremendous amount. So in 2019, it's up to almost 16 deaths per 100,000. But what you may not know, or what some people don't know, is that this started in a rise in prescription opioid overdose deaths, but now it's progressed into other waves. So in about 2010, there was a rise in heroin overdose deaths. So this increased substantially. And then in 2013, we've seen a huge spike in other synthetic opioids. So tramadol and fentanyl. So as we're trying to think about how to reduce opioids, this has kind of backfired to us in a way as people have moved into these more harder, worse drugs. So we all know that there's an opioid epidemic, but the deaths are, what does this mean? There's 70,630 deaths in 2019. So I think this number is so big that sometimes it's hard to get a handle on really just how bad the opioid epidemic is. So just for context, the opioid epidemic is worse than many well-documented societal problems. So one would be HIV/AIDS. At its peak, it was 50,806. So there's more deaths from opioid overdoses than HIV/AIDS in its peak, gun deaths in their peak, which was 39,000, and drinking and driving deaths in its peak, which was 26,000 in 1982. So this is a really substantial problem. Also, for even more context, opioid overdose causes more deaths than all car crash fatalities in 2016, and even more deaths than all American deaths in the Vietnam War. So this is a really substantial problem in the United States and just the world. If you want to think more about New Mexico, here's some facts about New Mexico. So the annual economic cost of alcohol consumption in New Mexico is $2.2 billion. And that's really high. So it amounts to over $1,000 per New Mexican, or $2.77 per drink consumed. And in 2010, New Mexico ranked the highest of all states in cost per drink consumed. So that's a kind of a weird metric to think about, but per drink consumed, New Mexico had the highest cost in the entire United States. If you want to think about substance use disorder fatalities, New Mexico is 10th highest in the nation. But in a little bit of good news, we haven't necessarily seen this astronomical spike that you've seen in the rest of the United States. So here is the deaths from the different types of opioids. It has gone up since 1999, but not this exponential growth you've seen in other states. Okay, so substance use disorders cause tons of problems for humans, and of course we need to do better in trying to treat substance use disorders. But a lot of people wonder, what does economics have to do with substance use? So what is an economist doing studying substance use disorders and substance use disorder treatment? So for a bit of background, it's not just dollars and cents. It's not just trying to say, well, here's how much this program costs, and here's how much this drives the economy or something like that. That's not what necessarily economists are truly interested in. So the idea of economics is really to create the greatest amount of good possible when there's limited resources. So for instance, like think if we had $1 million available for substance use disorder treatment. What economists' ultimate objective is to spend that money in the best possible way to create the greatest amount of good for people. So with limited budgets, there's a trade-off between perhaps more expensive clinically effective interventions and cheaper interventions that can reach more people. So just because one intervention, perhaps a inpatient treatment program that lasts a long time, if that has better outcomes, does that necessarily create more good? Well, not necessarily, if there could be another type of intervention that could reach more people. So given limited budgets, how can we create the greatest amount of good possible? And then economists are actually interested in another question, which is the overall societal impact of substance use disorder treatment. So maybe budgets aren't limited. Maybe we can convince the government to spend more money on substance use disorder treatment. And to do that, we want to find all the benefits that are caused from it and capture those, so maybe we can create an argument that more money should be allocated to substance use disorder treatment. Okay, so given that background, there's a sizable literature that finds that substance use disorder treatment has benefits that considerably outweigh the costs. So we'll study things like changes in crime, changes in employment, changes in healthcare utilization, all to try to create what is the overall economic impact of spending money on substance use disorder treatment? Okay, and so not only is substance use disorder treatment, substance use disorder is expensive and costly to society, so is crime. So it's actually extremely costly. So the cost of substance use disorders is as high as $544 billion. There's also substantial economic costs of crime. So close to 1 in 100 adults are behind bars, which is a crazy number. The cost of crime has been estimated to be as high as 1.7 trillion. And one thing when I first studied this, I was stunned to find is just the considerable recidivism rate that there is in the United States. So the Bureau of Justice Statistics found rearrest rates to be 56.7% for 1 year, all the way up to 76.6% for 5 years. So once people end up in the incarceration system, they are usually coming back, and the costs of crime are really high. So here's one thing that economists do that can be difficult is try to capture the cost of these really yucky things that can happen to people. So here's some costs that are estimated by McAllister et al. In 2017. But the point is that crime, not only is crime very frequent in the US, but it's also very costly. And here's a tricky point, is that I'm trying to think about incarceration-based substance use disorder treatment. Does substance use disorder cause crime? It turns out the literature is very hotly debated about this. There's a correlation between substance use disorders and crime, but we don't really know the causation. But nonetheless, there's a high amount of substance use disorders in jails. So half of prisoners meet criteria for drug dependence, and substance dependent prisoners are more likely to have extensive criminal records. Okay, so the costs of crime are very high. Costs of substance use disorders are very high. So how can we mitigate substance use disorders and crime and the associated costs? One possible option is incarceration-based substance use disorder treatment. So maybe we could reach people in incarceration systems, provide them substance use disorder treatment. Maybe that might reduce subsequent crime, and it might reduce substance use disorders and improve lives. So treatment within incarceration systems may catch more individuals that were not receiving community-based treatment. And also these programs may produce societal benefits. So what do we know? What do we know about the economics of incarceration-based substance use disorder treatment? Well, it turns out, as I said before, substance use disorder treatment is found to be very effective from an economic perspective. It improves health, reduces criminal activity, reduces substance use. For every dollar, so NIDA from the National Institute of Health found that every dollar spent on substance use disorder treatment, for every dollar that's spent, between $4 and $7 are returned in benefits. But substance use disorder treatment is rarely implemented in US criminal justice systems. We don't know that much about its impact, but this has actually been a high priority of funding institutes. So recently we're finding studies are starting to come out saying that incarceration-based substance use disorder treatment is effective in reducing post-release drug use and crime. But still, we don't know as much as we'd like to know about incarceration-based substance use disorder treatment. So that's where our paper fits in. So in our paper, we study the jail-based methadone maintenance treatment program at the Bernalillo County Metropolitan Detention Center. So just for a little background on the program, a methadone maintenance treatment program is operated as a public health clinic in the MDC since 2005, so quite a while now. And for background on the MDC, it's one of the 50 largest jails in the US. And this number kind of ebbs and flows and changes a little bit based on how you look at it. But the MDC releases approximately 25,000 inmates per year. So at the time of our study, the program only provided methadone maintenance treatment to inmates that had been receiving treatment prior to incarceration. So it's a methadone maintenance continuation program. That's changing. They've actually started inducting inmates on methadone, which is really exciting, and we're going to be trying to study that moving forward. But this study was just on methadone maintenance continuation, and the way people get into the program is that substance use disorders are identified through a medical screening. So when they go into the jail, they receive a a medical screening where they can screen for substance use disorders. Also, individuals can just opt into the program. So if they can't just say, I want methadone. Lots of people want that, but they can say, hey, I am addicted to substances, and then they can follow up with treatment programs in the community to check that. We collected 3-year pre-post reincarceration data for inmates that were released between July 1st, 2011 and December 31st, 2011. So you might think that data sounds kind of old, and to some degree it is. The study takes a while for studies to get published, but also to collect a good period of recidivism data. So you want to collect 3 years of post-recidivism data, you have to start a little bit earlier in order to collect that follow-up period. So from the sample, 220 inmates received methadone maintenance treatment. And we're going to compare this with a number of control groups. You need to have a reference point to see, did the program work or not? You need to have a different group that is your counterfactual to what might have happened if they didn't receive it. So we have a bunch of comparison groups. In this particular study, we found individuals that were detoxified from opioids, but did not receive MMT, people who were detoxified from alcohol, and then general population inmates. Okay. So I'm not going to spend a ton of time talking about our methods, but real quick, for one slide on this, first thing we worked on was an economic cost analysis. So you want to think about how expensive is it to implement methadone maintenance treatment in jail. So we actually wrote a whole paper on how much it costs. So you want to think about what are the different cost components, and if you were to replicate this program somewhere else, how much would that cost? So it turned out, actually, to give away the findings of the cost analysis, I'm not going to get into that too much in this paper, it doesn't cost too much more to implement methadone maintenance treatment in a jail than it costs to implement it in a community-based program. And that's largely because the cost of space, at least in New Mexico, in the jail wasn't very expensive. And you didn't have to pay a very high premium for people to work in the jail, which I thought might happen originally. Okay, then we're going to look at the economic benefits. So there's lots of economic benefits that can come from substance use disorder treatment. They can be progressively more difficult to capture with different populations. In this study, we're just focusing on recidivism. So we want to know, we're just looking at crime, and particularly just looking at crimes in which people were incarcerated for. So the point of that is that there's many additional things that we could study that could be benefits of this program. And I'm actually trying to work on that, but it can be difficult to capture detailed data from people who are incarcerated and then released in the community. But anyways, we collected 3 years of reincarceration data for all of our groups, and we actually collected incarceration data 3 years before the indexed incarceration event. And we did that, some of you may care, many of you may not care, but we did that because that helps us create a better matched sample in which to compare apples with apples when you're thinking about the effect of treatment. So we ran a cost effectiveness analysis. So real quick, here's what we're doing. So the numerator is the cost per inmate cost of treatment. So how much did it cost to provide treatment? And then what's the change in recidivism days? So you're going to divide the costs by how much it changed in recidivism days. And what we're going to get from this analysis is the dollar amount it costs to reduce our recidivism days. So when I say we want to compare how much the program costs with some outcome that we're interested in. And this particular analysis is going to give us how much it costs to reduce a recidivism day using jail-based MMT. And for reference, the average cost of incarceration for just 1 day of a person in MDC is $116.49. So if we get a number, if it costs less than $116.49 to reduce a recidivism day using jail-based MMT, well, then that program pays for itself. So that's kind of the idea of economic analysis here. Okay, so here's what we find. And here's the table one. These are just the cost estimates, like I talked about. So you might be interested in a couple things that we found here. First, here are the amount of hours that were spent in a program in a particular year. So in this particular program, the lion's share of the hours were spent on nurses that administered the methadone and did all the work in terms of getting it organized and getting it to people and then interviewing people and things like that. So 38% of the total costs of the program were for nurses. The program itself only had 900 square feet. And so actually the space that used in the jail were a tiny fraction of the cost of substance use disorder treatment in the jail. And then 10% was for equipment and services. Total cost of the program was $394,000 per year. Here is the overall costs of providing methadone mainstream in the jail. And by the way, we've done a lot more work that kind of thinks about like different aspects of this, but I'm just presenting the main cost results. So the average length of stay for someone in the MMT program, remember this is a jail, not a prison, so it's meant for short-term stays. So the average stay was 6 weeks. The average per client weekly cost was $115 per week. And the total economic cost to treat someone for methadone within the jail was $689. In case you're interested, here's some summary statistics for what our groups looked like. So the individuals receiving methadone in the jail, there's both male and females in the Bernalillo County Detention Center. So in our sample, 68% were male. The average age was 34.63 years. There wasn't very many African American or Native Americans, but there was a good amount of Hispanics in our sample. And then if you want to look at what their the 3-year prior incarceration looked like, the inmates had approximately 3 prior arrests on average and 85 prior incarceration days. And they stayed 51 days in the jail for that particular stay. So I'm not going to go through the rest of the groups, but if you're thinking about my empirical design, what you want is you want your comparison group to look similar so that it may be a reasonable counterfactual. And so looking here, it does look like our opioid, no methadone, people who received detoxification for opioids but did not receive MMT, they generally looked very similar, so which would make you think that perhaps it's a good comparison group. Okay, so if here are generally our main results for our whole study. So what we're looking at is we're going to look at the mean post-intervention incarceration days. So in the 3 years after they received methadone, how many days were people incarcerated on average? And we're going to compare that with the methadone maintenance treatment and the opioid no methadone group. And then we're going to think about, is this program cost effective or not? So the methadone maintenance treatment group had on average 105 post-intervention incarceration days, and the opioid no methadone had 135. So there's 29 less incarceration days for individuals that receive methadone. And according to our metric, it cost $23.49 per reduced incarceration day that was caused by the methadone maintenance program. So remember, the average cost of incarceration day is $116 per day. So you can either pay $23 to reduce an incarceration day using methadone maintenance treatment, or you can spend $116 just incarcerating that person. So these results strongly suggest that the methadone maintenance treatment program pays for itself based on reductions in recidivism. When you look at our other groups, the results hold if you look at the alcohol detoxification group, but do not hold if you compare them with the general population. And what do we make of that? I mean, there's a lot of things you could think about with that, but my take from this is that when you're thinking about studying opioid use disorders, you can't really use a general population. They're not similar enough to use that as a comparison group when you're studying. Okay, so moving on, and I'm going to go pretty fast because I don't know how much this group cares about the dirty details about making sure people believe us when we're presenting it. But like I said, we got all this extra data to have a better control group and perhaps address Sample selection bias, people who received methadone may be different than people who didn't. So we use a difference in difference model, which just compares both the pre-post differences between the groups. So you look at their before they were incarcerated and after, and you subtract those two, and then you compare those between groups. And when we do that, we find very similar results. So when we adjust for potential sample selection in our group, we find still that the methadone maintenance treatment program is highly effective from an economic perspective. Again, we're using this method called propensity score matching, which matches, creates a comparison group by matching. And again, we find even stronger results saying that the program is effective from an economic perspective. And then here's an interesting curve. So what this does, so this is our reference point, this $116. And that's what we're using to say, well, that's how much it costs to incarcerate people. So that makes sense to compare that number with the cost effectiveness results. But for some reason, policymakers may have a different idea of how much value to place on it. I mean, you could very well say we value a reduction in recidivism days by more than $116, but you could say less. So this says, what's the probability that this program is effective from an economic perspective based on different willingness to pay to reduce incarceration? So even if you only valued a reduction of recidivism by about $45, probabilistically, you're still saying that there's an 80% chance that this program is effective from a economic perspective. So this is another compelling figure saying that we really do believe that the Bernalillo County methadone maintenance treatment program is effective from an economic perspective. Okay, and so at the $116 mark, we're 93.3% sure that this program is effective from an economic perspective. Okay, last slide. Just to reiterate, substance use disorders hinder many aspects of individual lives, including health, employment, financial stability, and relationships. They're also associated with tremendous economic costs in New Mexico and the United States. One solution is incarceration-based substance use disorder. However, it's not really frequently utilized in the US. And maybe that's because there isn't that much known about both the clinical effectiveness and economic aspects. In this paper, we studied the MDC methadone maintenance treatment program. I found it's associated with both lower recidivism and its cost effectiveness. So we show that's $23.49 or $27 with this different method to reduce the recidivism day, and we actually spend $116 on it. So it makes a lot of sense to implement this in incarceration protocols. It's robust to a bunch of different models. So thus, our results suggest that this program is valuable from an economic perspective. However, there's still a lot of work to be done. So we really didn't have a randomized design. So it'd be better if we actually were able somehow to randomize people in a treatment to really know. We might want to think about a broader perspective, including not just reincarceration, but just the total crime that's committed, the societal cost crime, also healthcare utilization and employment. And also that turns out to actually be a little bit harder, but we want to look at the clinical outcomes. How many people actually got better, and how long did they engage with the methadone maintenance treatment program? And how long did they engage for, and did that work? We need to think about other populations in jail systems. And then, like I said, we want to think about methadone maintenance treatment induction rather than continuation. So right now, there is they are inducting inmates into methadone maintenance treatment in the jail, and we're actually trying, as we speak, to collect data on that, to study that. So that was my study, and yeah, I'm ready for some questions.
Great, Brady. Thank you so much for sharing all that information with us. I know that I came up with a couple of questions in order to help some of the programs that we have get a better sense of what it might look like if they wanted to implement their own MMT or different parts of that. So I think we've answered this question pretty well so far. Is it cost effective to treat opioid use disorders with MUODs in prisons and jails, maintenance, and does treatment decrease future drug use and criminal activity? So can you talk more about what types of future arrests you saw, or did you dig into the types of crimes that were committed after in the post session?
Yeah, that's actually a super interesting question. I'm trying not to I'm trying not to bore you with too many details. So one thing, I mean, I think I mentioned this, but we only looked at incarceration days in the jail in a 3-year window, but crime is incredibly costly. And so it's not just incarceration, it's actually like pain and suffering that people get from different types of crime. So we're actually looking at that right now. I can't remember off the top of my head, but there was 3 types of crimes that significantly changed. And so the estimates that we're coming up with, which are still a work in progress, but when you think about actually the human suffering costs of crime as well, like the numbers go up dramatically to something like $50,000 benefits for the program, like, not necessarily per person, but like, per crime committed. So we're really seeing like really enormous benefits when you incorporate the societal costs of crime as well. But those are still works in progress. So I'll share it with you once we get more final results. I'll give you more info on that.
Looking forward to it. Another thing that we've highlighted in the prior education series is data and how to store data, what data to collect. Can you tell us a little bit more where your data came from and the different streams of data that you had to bring in order to do this analysis?
Yeah, that's a great question. And turns out it is hard to study these types of questions. And the answer, like collecting data on this type of population can be difficult because you have to be careful with data, you have to be sensitive. So what we did, this program was nice because we pretty much knew, well, it's pretty clear that most individuals that committed crime and went into the MDC would come back. So if we just had their names and their date of birth, then we can match those with rearrest records. So for this data, it was somewhat straightforward that we just needed the names and date of births of people that went into treatment. And then we also needed data on the cost of the program. So I guess if I was going to think about future, what people would need for a study, like you really want to think about the cost components. Be careful, like most programs have information about what they're spending their money on. Then the next outcome would be to collect data on names and date of birth. So you can track those with administrative data sets. And then if you're really doing great, you can start trying to collect follow-up information on your patient populations in terms of things like, did they engage with substance use disorder treatment either in your program for a long time, or do they go somewhere else? We want to know, did they engage with substance use disorder treatment? And then there's a survey. If you're really trying hard, there's a survey instrument called the ASI or the ASI Lite, which have some questions that you can use for economic analysis.
Wonderful. I know that for a lot of us, data is just something that we use all the time, but I know for others, it's a little bit harder to conceptualize some of those things about where you might find it and stuff and things like that. So another question that I had is, what implications does the study have for other jails and prisons, specifically in New Mexico? Is this something that can be implemented? Is methadone maintenance feasible to implement in smaller jails? Is it being implemented in the other prisons?
Yeah, professors are very reticent to extrapolate their findings to other populations. So I think, in terms of policy in New Mexico, I think this is a pretty strong indication that substance use disorder treatment works. So medication-assisted treatment can work in an incarceration system. There's more work to be done to make sure that's correct. Can you implement it in other jails and prisons? The academic answer is we will have to find out. I can't say this guarantees it'll work, but it is an indication that it could work, and it's all the evidence I would need to say, well, let's give it a try. We have to study it, but I can't guarantee it'll work. But all signs suggest this is effective where we implement it now, and I don't see a reason why it wouldn't work on the place. There could be different costs, there could be different populations, there could be a litany of things that could be different, that could cause different results, but this is a very good pilot suggesting that it probably would work.
And would a good place to start be maybe looking at that previous paper you mentioned on just the cost analysis? So exactly what the program costs, and then you might be able to compare your situation with what's actually been studied already.
Yeah, so we actually tried in that paper to allow people, like we said, if your program looks like this might be the cost. If your program looks like this might be the cost. You could think about it may cost a different amount based on the size of your program and the population that you're looking at. So if you have a very small program, it's going to cost more per participant because you need to get the space and you need to get a clinician there to meet with people. So there's just some economies of scale associated with the program being somewhat bigger, and MDC is a relatively larger place. But yeah, I think that would be helpful for the costs. The benefits in terms of reductions in crime, we'll just have to do another study to find out.
And then you started to mention the current research that you're involved in, but what else can you tell us about the state of substance use treatment research around New Mexico?
Oh, wow. That's a big question. And I apologize to everyone that I'm missing for this. If you're just talking about substance use disorder treatment, there's a lot of research going on in New Mexico. So I'm a member of the CASA, so the Center of Alcoholism, Substance Abuse and Addiction. And there's lots of researchers there doing a lot of research on how we can do a better job, like just how we can improve our interventions to have even better outcomes for individuals. So I don't want to, they're studying alcohol, they're studying people's brains, they're studying medications. So there's a lot of work going on in substance use treatment. In terms of what my expertise is thinking about the intersection of substance use disorder treatment and incarceration systems. Because actually we have, like I said, we're studying the induction program at the MDC, which I'm excited about. There's one other thing that I'm pretty excited about that we're working on, which is studying prisons. And we're looking at, after someone was released from prison, if they received substance use disorder treatment, so they're outside of the prison system, does that change the probability they go back? Does it change their healthcare utilization? So we're using Medicaid data. And the question we're asking is, should we be turning on these, like, is it productive for society, not just the individual, but do we save money by turning on those codes to provide substance use disorder treatment? And so again, we are just starting to get access to the data, but I'm very excited to see the impact of substance use disorder treatment for prisoners that have been released from prison.
Excellent. I would like to open it up to any other questions at this time. If you're still with us and you have any questions that you'd like to ask Dr. Horn, feel free to use the chat or the question and answer function. While I'm waiting to see if anyone has any other questions, I'm going to go ahead and plug the next webinar that we have coming out, which will be Wednesday, May 19th. And the topic is competency and behavioral health, hosted by my colleague, Angelica Garule. I know she has at least one guest speaker to bring in on that as well. The registration link is on this presentation, and we can also email out the flyer for all of the future dates and the registration links there. So we have a question here in the chat. Are the results you report enough of an incentive for private prisons to implement MMT treatment? You see that in the chat?
I've not seen the chat, but I did hear your question. So I
Okay.
know the question. I'm just trying to get my chat up and running so I can see it. I think private prisons have a complex set of incentives. So I think, well, we're getting a little bit outside my lane here, but I believe that private prisons are in charge of a population, and so yeah, if you can if you set up the structure so that they manage a population, and then your population is going to be more healthy and come back less often, then these are strong results that we should be doing this in terms of private prisons. If instead that private prisons get paid per person that goes through their system, then they don't have as much of an incentive to try to do things to reduce that. So I think it really depends on, this is a really economic answer, I'm sorry, but it depends on the compensation structure for the private prisons. But I think in the way it's currently structured, that they would have an incentive to try to improve the health of their populations and then have lower costs as they move forward. It would just take a forward-thinking private prison to recognize that the benefits that you're getting are in the future and your costs are now. So you have to sink a little bit of money in today to reap all the benefits in the future.
Yeah, and I know there's plenty of studies about people's willingness to invest in future profits as well, but that's probably a topic for a whole nother day. All right, well, I do not see any other questions coming in. I know you can always email Dr. Horn or the Sentencing Commission with any future questions that you may have. I'd also like to remind everybody that grant applications are due May 7th. So be looking into applying for those on our website, nmsc.unm.edu. And Dr. Horn, thank you so much for your time and information. I know I learned a lot, and I hope everyone else did as well.
All right. Thanks for having me.
All right. Thank you.